Okay, thank you. And so I'll start with saying I do see now that we are all staff. Oh, we have a parent who is joining us. Here, I'll wait till she enters and then I'll begin. All right, Estelle, thank you for joining us today. And now that we're beginning, so welcome everyone to our Lunch and Learns. They've been wonderful opportunities for us to gather together as a group with parents, with staff, and really get some good resources. When we invited Dr. Enlow, it was now a couple months ago when we met with him and invited him to join us to talk about the very important topic of supporting good behavioral health with our students, as well as identifying behavioral health issues and challenges. We had no idea how pertinent that subject would be for this week in particular. And so, Dr. Enlow, we are grateful you are here with us today. I'll tell everyone a little bit about you and the way that our Lunch and Learns work for staff that are newer to joining us. And Estelle, thank you so much for coming today. We know that you've come to others. Is they are recorded, they're sent out to all families so that they can watch at a more convenient time if helpful. And they're pretty informal. Typically our speaker presents, then we have a question and answer session. And they're a really nice way to share additional resources to help support what we do and help support families with all that they do. Today we have Dr. Paul Enlow. He is a pediatric psychologist in the Nemours Division of Behavioral Health and an assistant research scientist in the Nemours Center for Healthcare Delivery Science. Dr. Enlow earned his PhD in clinical child psychology from West Virginia University in 2017 and completed his residency and fellowship at Nemours. He currently provides mental health services to youth and families in the inpatient and outpatient rehabilitation programs at Nemours. Dr. Enlow also conducts research to improve the mental and physical health of youth with chronic medical conditions. This is a topic that we discuss all the time at HMS. And so when we met Dr. Enlow via a Zoom conference and heard that he does research specifically on a conversation topic that we have frequently at HMS, he seemed like a perfect fit to invite. So thank you so much for joining us today. And without further ado.
Yeah. And thank you guys for inviting me. You know, I'm always happy to and excited to talk about these topics. So I'm going to share my screen. Can everyone see that? Yep. Okay. So thank you for the great introduction, and again, thank you guys for having me. Today, I'm going to be talking about mental health in youth with cerebral palsy. The hope is that we can, I can just talk a little bit about kind of what we know, and then I can go from there, and we'll have some time for Q&As afterwards. Just make sure. Oh, perfect. So today, the way I'm going to kind of structure our time today is to talk a little bit about just kind of what is mental health in general, how do I think about it, and how do we like to encourage families and patients to think about mental health as well. I'll include some statistics as well as some kind of caveats about interpreting these statistics. We'll talk a little bit about how to help both in the everyday setting as well as in more formal ways like therapy and things like that. And then at the end, we'll have some time for Q&A. So to begin, I wanted to talk just about what is mental health. So a lot of times mental health is thought of as just the presence of a mental health disorder. So anxiety, depression, behavior problems, things like that. But mental health is I like to think of mental health much more broadly. So mental health is kind of made up of our emotional, our psychological, and our social well-being. So it's kind of how we act, think, and feel in our day-to-day environment. And this can be in both good ways as well as in not so great ways. And as we're going through the facts and figures and statistics and all of that, I think that's something important for us to think about, is that mental health doesn't just have to be negative, it can also be positive. So we want to support positive mental health while also trying to limit more negative mental health. One thing that I often focus on, especially when I'm talking with families, is an important part of mental health, especially when we talk about disorders, is whether or not these behaviors or these thoughts have an impact on our functioning. So that's one of the most important critical things. And I use this example, I think it's a great one, because sometimes we can have fears or we can have behaviors that don't really impact our day-to-day functioning. And so we might actually not say that that is a mental health diagnosis or a disorder. So when I was in graduate school, one of my colleagues went to South America and he provided mental health services to children down there for a summer, which was a really cool experience. And when he shared it with us, one of the most common fears that he dealt with was a fear of volcanoes. So down in South America, there were a lot of volcanoes and they're active. And so many of these children had fears of a volcanic eruption, of something happening. And it was kind of like we might here in the United States deal with kind of a fear of dogs or a fear of heights. And it had to be treated because these children had to go outside, they had to go to school, they had to go to the grocery stores in order to get through their day-to-day life. So that fear of volcanoes was really impacting their daily functioning. Now, working in Delaware, if a child came to me and said that they were afraid of volcanoes, that might not really impact their day-to-day life because they can get around. I'm not aware of any volcanoes in Delaware or anywhere nearby. So, that fear and those behaviors probably wouldn't impact their day-to-day functioning. So, there are times when we might feel sad, we might feel scared, we might act a certain way, and it might not impact kind of our daily lives, and so we might not view that as negative mental health. Another way I like to think of mental health, particularly when we talk about things not going well, is that there are kind of different tiers. So in general, we have kind of more normative concerns, normative mental health. Laura and Diane had shared with me that there had been some students who have passed recently. So, a normative experience from that is grief, sadness, feelings of loss. And, I, as a psychologist, am not going to say that, having those feelings or feeling that way is pathological or bad. So that's an example of normative mental health. And then, going up from that, there can be kind of subclinical symptoms. So sometimes we talk about those as pink flags rather than red flags. This is where I like to catch kids, is to intervene before things become a problem, but when they start to become a problem. And then clinical symptoms, which are much more kind of pronounced problems that are affecting kind of either daily life or maybe just functioning in one specific area. There are also different types of mental health. So again, mental health disorders are what a lot of people think of when they hear the term mental health, but I also think of quality of life. And so I'll go through some of the common mental health disorders today. I won't go through the less common ones, but happy to answer questions if people do have questions about that. So quality of life is really important because quality of life is a person's perception of their position in life that takes into account their value systems, their culture, and their goals. So quality of life can be made up, it's usually kind of divided into three parts. There is physical quality of life, psychological quality of life, and social quality of life. So each of these areas we look at kind of, so if we take the social part of quality of life, we look at, based on a patient or a family's culture or what they value or their goals for their life, what does their social quality of life look like? And that definition may differ for different people. So an example I use is if you're a very extroverted person and you want to be friends with everyone, your social quality of life might not be high until you're very popular, until you have a social activity every single day of the week, things like that. But for someone who's more introverted, who likes to have a smaller group of friends, and doesn't necessarily want to go to a party or a social event every single day, they might be more content or report having greater social quality of life if they just have one or two really close friends, or they're able to spend one day a week with their best friend. So quality of life is great because it is patient and family centered, and we can evaluate it that way. So looking at quality of life in youth with CP is important because it goes beyond just are you healthy to kind of are you thriving? And it's interesting because quality of life, the evidence about like, what is the quality of life of youth with CP, it's actually kind of mixed. So sometimes there's an assumption that if you have a physical disability, if you have a medical condition, your quality of life is automatically going to be worse. And this is a lot of times because the quality of life is the norms or the standard metrics for what is considered good quality of life is measured with kids who don't have medical conditions, who don't have mental health conditions. So we would assume if you have some kind of condition, you're going to have worse quality of life, but it's a little bit mixed, and I'll get into that in this slide and the next. So when we break quality of life down into the 3 different categories, physical, psychological, and social, we do see that kids with kids with CP tend to have lower physical quality of life when compared to youth without CP. But I don't know if that's that surprising. A lot of kids with CP have deficits in, motor deficits. They have difficulties walking. They might have difficulties with more fine motor movements due to spasticity. So it's not surprising that kids with CP have lower physical quality of life. It may be expected because someone without CP might not face those same challenges. Moving on to psychological quality of life, this is when we start to look at things like mental health, but also things like self-esteem and self-concept. So mental health is mixed, and with some youth with CP reporting worse psychological mental health, having more mental health symptoms, and some youth with CP reporting that their mental health is actually the same as kids without CP, or maybe even better. The findings and data about self-esteem is a little bit more concrete. So youth with CP do tend to report having lower self-esteem, lower self-concept compared with kids without CP. And then I think social is where it gets even more interesting when you look at quality of life. Families of youth with CP report more disruptions in their family, but that's also to be expected. There's more doctor's visits. They might have more needs than a family without a child with CP. Some parents and some families and some youth report lower quality social relationships. For youth, this may be because they might be bullied in school, or maybe they're treated differently. But there have also been a handful of studies that have actually reported youth with CP feel that they have higher social quality of life, that their social relationships are more meaningful or more valuable to them, or maybe even more rewarding. I sometimes talking about mixed evidence is challenging because we don't have a definitive answer. I can't leave here today and say this is what it is. But what we can say is that just because a child has CP, because they have physical disabilities, does not mean that they have low quality of life. It might happen, but there are things we can do to try and improve that quality of life. I think the important thing to also keep in mind is that a lot of these comparisons are made to youth without cerebral palsy. So there are some measures of quality of life that are specific for kids with CP. The challenge becomes that sometimes they rely on the parent to make all the ratings, which is great if a child is not able to complete the rating forms and things like that. But the measures of quality of life that the children complete, the child has to be, they have to have the cognitive ability to do that. So even though it's great that we have CP specific quality of life measures, it's still not perfect because we can't assess every patient the same way. So what makes quality of life better or worse? So this is what I think is really important. So functional status is interesting because it does predict physical quality of life, which makes sense. Patients who have more functional deficits tend to rate lower on physical quality of life measures because that's what those questions ask about. But functional status does not predict social or psychological quality of life. So just because you may have more functional deficits does not mean that you're going to have worse mental health, does not mean that you're going to have worse self-esteem, does not mean that that child's going to find social relationships less rewarding. Physical activity is a pretty strong predictor of both physical quality of life, which makes sense, but also social quality of life. And the great thing about the physical activity data is it does not mean that your child has to be playing sports. It does not mean that they have to be, it doesn't really specify what type of physical activity is good. It more just says that the more physically active you can be, the better you tend to be in these different domains. So that means that we can adapt that definition of physical activity for what's going to meet the patient's needs, what the patient is able to do. Mental health disorders are in general associated with worse overall quality of life. So if children present with mental health disorders, we want to make sure they get treatment, and that kind of makes sense. And then the last one is caregivers. And I know that we have a lot of staff on here, so I think staff are part of this. I also, the parents are also part of this. But parent-child conflict is strongly associated. More conflict, worse quality of life. Caregiver mental health is a really strong predictor of child mental health and child quality of life. So the more that caregivers can take care of themselves, the better the children tend to do. And also parenting stress. So that's kind of in that subclinical level where you don't have a clinical mental health diagnosis, but you're experiencing a level of stress. So parenting stress, more stress is associated with worse quality of life. So caregivers are really important. You guys are your child's kind of you're their world, and taking care of yourself, although sometimes that's not the first thing we think about, is really important for taking care of kids. So over the next few slides, I'm going to start talking about specific mental health disorders. I'm going to kind of go through these a little bit quickly. Some of them are pretty self-explanatory, but if you have any questions, I'm happy to talk a little bit more at the end as well. So behavior problems are one of the most common reasons that children come to see psychologists. So this can be things like not listening or acting out. It can be things like hyperactivity or inattention, breaking rules, and then, in kind of the more extreme end of the spectrum, purposeful aggression and purposeful violence. It's different than kind of like accidental, like accidentally hitting or pushing, that we're talking more about like, I purposefully am trying to hurt you. That's pretty unusual. But in general, things like not listening, acting out, hyperactivity, even breaking rules are pretty common reasons kids come to see me or one of my colleagues. So behavior problems start early. We see kids come as young as 2 years old for interventions. Although disorders like ADHD, we don't typically diagnose them until they're at least 5 years old. The main reason is because the normal attention span for a 4-year-old is pretty varied. Some kids are great at paying attention for long periods of time. Some kids, they 30 seconds and they're kind of done with whatever's going on. So the range of normal is pretty wide. So we wait until they get older to make those diagnoses. So I have figures that show the prevalence of mental health disorders in the general population compared with cerebral palsy. These data are pulled from a variety of different studies. So that's something to kind of take in mind. They aren't all from one big study. The other thing to keep in mind, and we'll kind of come to this at the end, is again, we are comparing youth with cerebral palsy to the general population. And sometimes symptoms of mental health disorders might also overlap with symptoms of cerebral palsy. And I'll talk about that more a little bit at the end. But just looking at this, you do see that more children with CP have behavior problems and have ADHD diagnoses when compared with the general population. Anxiety disorders are another really common referral. These include things like uncontrollable worry, physical symptoms, particularly in young kids or kids with developmental delays. They may not say that they're worried about something, but they might say that their stomach hurts, they have a headache, they feel sick. Some kids actually throw up. But it's more of nerves than it is like a physical ailment. Anxiety can also present as difficulty concentrating. It can present as things like school refusal or avoiding situations or things that cause fear. So anxiety disorders are pretty common, but they differ. So separation anxiety disorder usually occurs in younger kids, the 2 to 5 year old range, while other anxiety disorders don't tend to, we don't tend to see them until kids are older, 9 years old or older. And that's because anxiety is a little bit more of a kind of cognitively sophisticated disorder. It's being worried about things in the future, things that might happen. So younger kids tend to focus on the here and now. So we don't see things like generalized anxiety or OCD or anything like that until kids get older. So the prevalence of anxiety disorders is kind of variable. We do see more diagnoses with generalized anxiety and OCD in youth with CP when compared with the general population. But separation anxiety disorder is pretty close. It's like 4 versus 5%. That's not a huge difference. Panic disorders, they're slightly lower in youth with cerebral palsy compared with the general population. And phobias actually tend to be more reported less in youth with CP than in the general population. We don't really have a great explanation as to why that occurs. That's kind of what the data is showing, at least right now. Depressive disorders are, again, something that I tend to work with kids a lot, specifically kids who have some kind of functional deficit. Sometimes they might feel down or sad because maybe they start to notice the difference between themselves and their peers. Sometimes they're not able to do the things that they really want to do. So they can present with things like depressed or irritable mood. Irritable mood is kind of more like everyone annoys you, just leave me alone. Think of kind of like your classic teen. That's irritable mood. That's pretty common in teens when compared to adults. So we tend to see irritable mood more in kids. Depressive disorders also include things like just you don't really like doing anything anymore, changes in sleep and appetite, feeling like you're not worth much. And we can also sometimes see frequent thoughts of death or maybe even attempting suicide. So depressive disorders, again, we tend to see in older school-aged kids and older. We do see a greater prevalence of depressive disorders in youth with CP when compared with the general population. Autism spectrum disorder, I know this is a wall of text and I apologize, but I wanted to be thorough. We do see, so this is, just in general, autism spectrum disorder is diagnosed when there are deficits in social communication and interaction, as well as specific patterns of behavior that tend to get in the way of their day-to-day functioning. So we look for symptoms in both of these categories in order to diagnose autism spectrum disorder. This may be something that you guys are kind of familiar with. The age of onset is usually 2 years old and up. The prevalence of autism spectrum disorder is, again, much higher in the CP population when compared with the general population. Again, this is where it gets kind of tricky, where sometimes the symptoms that we might use to diagnose autism spectrum disorder also overlap with symptoms of CP. So youth with CP often have, some youth with CP have communication deficits. They might have repeated kind of repetitive movements and behaviors or fixated interests. And the question becomes, is this autism spectrum disorder or is this really CP? And so when we see this overlap, the question I have is kind of more like an academic psychologist is thinking, is this truly a higher prevalence of autism spectrum disorder, or might the diagnosis rate be a little bit higher because they are getting diagnosed in different ways, or we're looking at symptoms maybe the wrong way. The last disorder I wanted to kind of throw in there, and this is something that I see a lot and I work with a lot, is adjustment disorder. So an adjustment disorder is a brief period of anxiety, depression, or behavior problems that are related to a specific event or an incident. So I work with kids in the hospital. I see a lot of adjustment disorders where kids are missing home, where kids are feeling down because they can't see their friends, or they have to listen to the nurse who's telling them to take the medication time and time again. So we might see acting out, anxiety, or depression. The key part of adjustment disorders is that they are related to a specific stressor. And as soon as that stressor goes away, we would anticipate that the anxiety, depression, and behavior problems are also going to go away. So, with adjustment disorders, we usually focus on how can we get you through this period of time here and now, and then we'll focus on, the long term. So Like I said before, when you think of those facts and figures, there are a lot of things to keep in mind. The first is that in youth with cerebral palsy, there's a wide amount of variability in severity, impairment, and comorbid medical conditions. So for kids who have more severe CP or more impairments, it may be harder to diagnose some of these disorders compared with kids who have fewer impairments. And so a lot of times we need to focus more, and remember when I was talking about that functional impairment, is this getting in the way of a child's day-to-day life? Sometimes we focus a little bit more on that than just is the symptom present or not. The other thing, like I said before, is that symptoms of CP overlap with symptoms of other mental health disorders. So inattention is one that's really challenging. If I have a child who has a developmental delay, and let's say that they're 10 years old, but maybe developmentally they're closer to a 4-year-old level, it might not be appropriate to diagnose them with ADHD if they have inattention, because developmentally it might be more their attention level might actually be appropriate. Arguing and crying. I'm cautious to immediately say, oh, this is a child who has oppositional defiant disorder, because it may be a communication impairment, and maybe our intervention is not around behavior management strategies or parenting strategies, but is instead focused on how can we give this child a way to express themselves in a way that's functional, in a way that gets them what they want. So, sometimes we need to kind of think a little bit deeper than just, is the symptom there or not, but instead, like, what is contributing to this, and how is our intervention going to take that into account? So I'm keeping track of our time. We're about, I want to maybe try and stop around quarter till for questions. So I'll get through these next slides. So talking about, we want to tailor our intervention to the symptoms and to the child and kind of what they need. In these next few slides, I'm going to talk about how can we help. And we'll talk about everyday recommendations and also just a little bit about evidence-based treatments. So I'm going to start with caregivers, because you guys are very important. You guys see your children way more than I do. I see, most of the kids I treat once a week, maybe once every other week. You guys see your kids 24/7. So you guys have a very strong impact on your child. And caregiver psychological functioning is, time and time again, found to be one of the strongest determinants of child outcomes. And I sometimes hate saying that, because caregiving isn't easy. You have the stress of caring for a child, and then if I also say, oh, and by the way, take care of yourself, because that's going to take care of your child, sometimes I feel like we're putting, parents in a really tough spot. But I think it's something important to keep in mind that, self-care as a caregiver is also going to help your child. So I talk a lot with caregivers about practicing self-care. And when I talk about self-care, I'm not talking about going on week-long vacations and going on cruises and, getting spa treatments weekly. We're talking more about making sure that you're getting regular sleep schedule. You're having as regular sleep schedule as you can have, getting 3 square meals a day, staying as active as you can be. You don't need to be a marathon runner, but, getting out of your house can be really helpful. And also, staying close to your social support network. Those things can be really, really important. Help take care, kind of like refill your tank every day, so then you can go back and you can give to your child. You can give to the other people in your life who you need to give for. Also, changes in routine and self-care are the norm. If you think of the COVID-19 pandemic, our entire routines and our ability to care for ourselves has been thrown for a loop. And so it's disingenuous, and it's not very fair to tell people like, oh, hey, I know a pandemic is occurring and you might now be working from home while your kids are also there with you, but you have to maintain the same amount of professionalism and your routines cannot change. Like, that's not realistic. And that actually is pretty invalidating of people's experiences if we say that. Instead, the way I try to think about it is that things are going to happen, but we want to try and minimize the impact. If our boat, that we're riding on gets capsized, we want to try and right it as soon as we can, but recognizing that, we might not have been able to do anything about that disruption. The same thing, same thing occurs for things like personal and medical crises. So, as a caregiver of a child with CP, you have a lot more doctor's visits than a child, the caregiver child without CP, which means you have you may have more hospital admissions or surgeries. And to say that those things are not going to disrupt your daily routines or your self-care that's not true. That's a lie. So it's figuring out when those disruptions do happen, what are the things we can kind of fall back on in order to make sure that we do try and take care of ourselves at least a little bit until things get a little bit easier and we get through that rough patch. All right. So moving on from caregivers. So all of the next things I'm going to talk about, I talk about a little bit in the context of the child, but I think it's also applicable to us being adults. So I think it also applies to caregivers. So emotions are something I talk about a lot because emotions are sometimes categorized as good or bad. It's bad when you're sad, it's good when you're happy. I don't like that because emotions inherently aren't good or bad. They're feedback from the world. They're telling us what is going on. So rather than focusing on are we happy or are we sad, I want to focus on how are we handling these emotions. If you are sad because a pet died, but then you are able to go back and go to work and things like that, that's totally appropriate to feel that way and then be able to engage in your daily life. But if it's been 6 months later and you haven't been able to spend time with friends and things like that, that may be a not great way to be handling those emotions. I talk with parents a lot about what I call emotion coaching. So it's a 5-step process, which the goal of this is really, and I have the steps listed there, but the goal of this really is to communicate with children more about emotions and then help them come up with a plan about how they're going to cope. So if a child comes up to, I'm working with a child and they talk about how they're really mad at their sister because their sister broke their Nintendo Switch. I would, if I had a Nintendo Switch and my sister broke it, I would also be very angry. And so it's appropriate to feel that way. Hitting your sister because she did that is not a great way to cope with that. Instead, there are better ways we can do it. So we can talk about kids with, okay, you can go to a calm down spot. You can go and talk to mom and dad about what to do. So that's kind of the goal of emotion coaching, is to validate those feelings, not to tell them like you can't feel that way. Instead, say like, I get it. I understand why you're feeling that way. Let's figure out what we can do to help you feel better. Emotion coaching is great because it's adaptable. So working with kids who have either communication impairments or cognitive impairments, it's something that you can adapt. For kids who have either communication or cognitive impairments, rather than doing it as a conversation back and forth, I will sometimes use visuals. And also sometimes we get a little bit more simple with the emotions. So rather than saying, are you feeling happy, sad, scared, frustrated, we might start very simply and say like, are you feeling good or are you feeling down? And then we can go from there. So what is, you're feeling down, what is making you feel down? What can we do to help? Things like that. I've also had some success with working with kids on the color rating system. So they might say like, are you in the green, are you in the yellow, are you in the red? And then that can again help the second part of emotion coaching, which is problem solving and coping. Coping is also, modeling healthy coping is another kind of everyday thing that caregivers can do to help their child. So again, your child's world, they look up to you. Kids, kids listen a lot more than we maybe give them credit for sometimes. They're very aware. So they see how we're handling problems. So, doing things like modeling healthy coping strategies, your child is more likely to do to try and cope that way too. So, using exercise as a coping strategy is great. Using problem solving as a coping strategy, children will see kind of how you problem solve, and they can then help. They can maybe try and apply that the next time too. Leaning on your social support system. If you're talking to your kid and you're saying like, yeah, I got really frustrated with something at work, so I talked to my best friend. And then they start to realize, oh, that's an option. I can do that if I'm feeling that way too. We can also directly teach coping strategies too, which I love doing. So structured problem solving is great. I use this a lot with kids. And it can also, again, be adapted for kids who have who are more impaired. So I use it with kids with CP as well. So it's as simple as kind of identifying the problem, coming up with solutions, weighing the pros and cons, and then picking one and going with it. I also like using what I call coping cards. So I'll sometimes usually get those like 3x5 note cards, put them on a 3-ring or one of those little rings, and we'll write out different strategies, different things they can do. And sometimes we might even pair it with common situations. So if, for example, the child has a sister who really annoys them, we might say, okay, when your sister annoys you, when your sister won't leave you alone, here's one thing you can do. It could be go to your room where your sister won't follow you, or go do something with mom or dad where you know that they won't bug you as much. So I like coping cards because they're concrete, they're reminders, and kids can keep them with them at all times. The other thing I really like is parents using appropriate self-disclosure. So, we don't want to, air all of our dirty laundry to our kids, but it can be an opportunity for us to help them, one, show that you've gone through the same problem. Nothing feels greater as a kid than when your parents say like, oh, I had that same problem. That feels pretty validating. The other thing is it gives you an opportunity to give them some potential choices or solutions about things they can do. So you can say like, I remember a time when my sister was really bugging me and I did this thing. I, included her in our game rather than trying to exclude her. And then you know what, she really left me alone because all she wanted to do was bug me. Thoughts and attitudes are really important too. So we want to try and help kids recognize unhelpful ways of thinking and unhelpful attitudes. So, a classic example for a kid might be that they can't come to his birthday party, and all right, I have to tell my friend that they can't come to my birthday party, and the person's going to hate me. They're going to be really mad at me. So we might instead talk with them about changing the way they're talking about that thought, saying, rather than saying like, Jason is going to help me or going to hate me, might say that I'm worried that Jason is going to be upset because I can't come to his birthday party. We can try and change that thought. We can say like, oh, like Jason and I have been friends for years. He's not going to care if I can't come to his birthday party. Or we can try and problem solve. We might be able to send a gift or a card because we can't be there. One of the things that can be more difficult is kids who have communication impairments or kids who have cognitive impairments might have harder time recognizing and changing thoughts. It's very abstract. It's something that we can still try and do, but the more concrete we can make it, the more successful it will be. So sometimes the way I will do it is, rather than saying, well, let's try and change our thought about this situation, it's instead doing the problem solving or trying to highlight both positive and negative things that have happened rather than just focusing on the negative. So some of these strategies are a little bit more difficult to adapt, so it might not be the best fit for that child, but we can still we can try and adapt and see what happens. We're not likely to do harm with any of these things. For the next few slides, I'm just going to talk about the warning signs for worsening mental health, and then just some general treatment approaches that we take. So warning signs include things like persistent changes in mood or behavior. So things have not gotten better. It's been 6 months, it's been a year, and we're still feeling really down, or we're still acting out. Also, in addition to persistent changes, we can also look out for severe changes. So if a child, is, skips school once, I might be more concerned that, okay, that's a pretty significant rule breaking. That might be a behavior that maybe we need to address. A kid who doesn't listen to their parent once, I mean, that's being a kid. So sometimes we also take into account the severity of the symptom. We also look for changes in daily functioning. So changes in school, like school performance, or maybe just not wanting to go to school, withdrawing from family or changed relationships with family, or maybe even withdrawing from friends or changed relationships with friends. Those might also be warning signs that they need a little bit extra support. So one of the most common treatments that I use is behavior therapy. So this focuses on behavioral principles to modify behaviors using things like timeout and reward charts, but also really simple things like praise and ignoring are actually usually the first behavior management strategies I start with before I get to the more higher tier things like timeout and reward charts. Behavior therapy focuses very, very strongly on the caregivers. So I'm working very closely with parents about what strategies they're using, what strategies are effective, and how we might be able to problem solve and implement strategies that really aren't working just yet. The good thing is that there's a robust amount of evidence for behavior therapy being effective for behavior problems. It can also be effective for some anxiety disorders. So actually the treatment of choice for things like selective mutism, that's kids who just don't want to talk, or separation anxiety disorder, kids who don't want to be away from caregivers, is a behavioral approach. Less about kind of the cognitive behavioral approach, which I'll talk about next. Instead, we're really just focusing on pretty much having kids do, we call them brave behaviors, but it's pretty much do the thing you're scared of in a controlled way, and then we reward you when you do it or when you follow through. So we're kind of changing the way we're reinforcing those behaviors. The great thing is that behavior therapy tends to be effective for kids regardless of their developmental age. So it's a treatment that I find myself using quite often. Cognitive behavioral therapy is probably what a lot of people think of when they think of like going to see a psychologist. So it's focusing on changing our thoughts, which we call cognitions, and our behaviors. So we might focus on relaxation strategies to help with things like anxiety. We also might try and recognize and challenge unhelpful thoughts, and also changing behaviors that maybe are not that great. So this model down here that you see is like an ABC model. So we talk about like the situation causes us to think, feel, and act differently, which has consequences that can be both good and bad. So while CBT is kind of the bread and butter of most psychologists' toolbox when working with youth with mental health disorders, the evidence base for youth with CP is kind of mixed. This is because youth with CP have a wide range of cognitive abilities. CBT tends to be a little bit more effective and a little bit easier to use in kids who are closer to kind of be cognitively normative. And also communication deficits tend to make CBT a little bit difficult. Studies that have been successful in youth with CP have incorporated caregivers a bit more. So teaching these strategies not only to the kid, but also to the caregiver, and then the caregiver can kind of help support the child in implementing them. And again, we go from kind of more abstract to trying changing thoughts and things like that to focusing more on things like problem solving. So we use the same general approach, but it's kind of, we just shift our emphasis, we shift our focus. So medication is another avenue for managing mental health concerns. So as a caveat, I am not a physician, so I can't endorse a specific medication for a specific disorder. Go to your pediatrician or a psychiatrist for that. But in general, we know things like antidepressants can be very safe and effective for anxiety and depressive disorders. Stimulant medications can actually be effective for inattention and hyperactivity. Sometimes psychiatrists will use atypical antipsychotics for more severe behavior problems, and those can actually be pretty effective if used, and safe if used correctly. A combination of treatments tend to be the most effective. But obviously that depends on each patient and family. And like I said, just consult with a pediatrician or a psychiatrist. So as much as I wish the mental health system was easy to navigate, it's not. So the first way to try and get treatment would be to go to your pediatrician or your physician. Sometimes there is a mental health provider integrated into that clinic, or they might be able to refer you to providers who they have good relationships with. There are some great resources from professional psychology organizations. I also strongly recommend university psychology departments. This is kind of where the up-and-coming psychologists train, and they get really good supervision, and you have a very invested therapists. So usually the treatment's just as high quality as what you might be getting in a hospital setting or a private practice setting. And then finally, talking to the insurance company about who's in-network and out-of-network. I always include this just whenever I talk about getting mental health resources. So mental health emergencies, those resources are getting better. The National Suicide Prevention Hotline is one that we use. I give to teens a lot. There's also Mobile Crisis. You can search Mobile Crisis in your state in Google, and those numbers will pop up. Nemours also has a line for mental health emergencies. And then lastly, you can call 911 or go to your local emergency department. So thank you so much for listening. We have some time for questions, so let me, yeah, any questions you have, I'm happy to talk about them.
Yeah, I have a question.
Mm-hmm.
So when addressing like students with CP, like students and children with CP, I remember you mentioning a lot about like talking about how to restructure thoughts more rationally and stuff. Like, would you say that that's important to do even in the case that the communication isn't uh, like necessarily clear, or like there wouldn't really be a way for the student to communicate that?
Yeah, I think it can always be helpful. Most of the strategies when we're talking about like trying to change this or do something differently, it's unlikely to be harmful. Um, a lot of times with kids who have more communication deficits, I will, at the beginning, I will model a lot more for them. So, for example, if just going back to kind of a simple example of maybe they're feeling um, sad because uh, uh, something happened to them. We might be able to try and actually restructure those thoughts for them. We might be able to say like well, we might feel sad because this happened, but we can also focus on the memories we have or good things that we have that happened as well. Sorry, no, it's hard to think of how to do it without like a specific example, but you can model it for kids, definitely.
Yeah, kind of just like bouncing off of that. The reason that I ask is because I feel like I'm afraid of maybe placing those thoughts like ahead of the student actually thinking about the things and saying like, as an example, maybe I was thinking this way, and then I'm then like saying like, what am I trying to say? So it's just like implementing a thought that maybe the student didn't actually have about a situation, and that's like restructuring a way of like first going into it and then saying like, here's a way to think differently when it might not have even been an issue to begin with.
Yeah. So I do trust that you guys know your students very well, and I think you guys probably can pick up on like if something might be happening, if they might be feeling a certain way. Sometimes if I'm unsure, um, so to go back to things like emotion coaching and things like that, one of the things I think is good is to be wrong about how a kid is feeling, as weird as that sounds, because that gives them an opportunity to say like, no, that's not how I feel. In fact, I feel this way. And sometimes that can be really good because it gives a child a chance to express how they are feeling. And then the other thing is it just facilitates the conversation around this topic. Um, when we get to kids who have a hard time saying like yes or no, like I do feel this way or I don't feel this way, the way that I might approach it is you could either share and say like I was feeling this way when this thing happened and here's what I did, kind of that modeling approach. So that way it doesn't really matter if the kid is feeling that way or not, but they can kind of see that process laid out for them. So they can see like, oh, like, okay, if I'm feeling sad, then I can do these things to help me. The other is sometimes we'll do it in kind of more of a hypothetical way. So we'll say like, all right, we're gonna practice helping someone who's feeling down or feeling sad or feeling scared, and here's some things we could do to help them either challenge that thought or try and change that thought. So that helps you kind of like avoid the like, are you really feeling this way? You're not feeling this way. While still, again, you're focusing on the strategy or that kind of the coping strategy. Yeah, it's a good question.
Yeah.
Dr. Enlow, if there are no other questions, thank you very, very much for joining us today. This was extremely informative, helpful, and I think it'll also spark a lot of thoughts and questions. And so if there are any additional questions, please email me or Diane, and we can forward them on to Dr. Enlow for some additional guidance. Thank you so much.
Thank you, guys.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.